alaikum. Inshallah, today we will talk about LDD, lumbar disc disease. A lot of tips we are discussed in the previous video about spine exam. We are talking about detailed history and neurological examination, and I think this will help us in our topic more than you think. I think by the end of spine you can review all topic within 1 hour, inshallah. Please focus with me. We will take a chapter called Basic Science. We will talk about every detail about disc development and its parts, but simple note related to our topic. I want you to know that the disc has annulus fibrosus, which is the outer rim, outer part of the disc, and inner nucleus bulbosus. The outer rim is attached to the bone, so it is formed by type 1 bone, type 1 collagen. And the nucleus bulbosus is a gelatinous material, has a lot of water, H2O, so type 2 collagen, mainly type 2 collagen. Okay. The second part is that the root coming below the pedicle, numbered according to the number of the pedicle. Let's go. Basically, this part is the spinous process. This part is the spinous process, and the adjacent to it is the lamina. This is the lamina. This is a superior articular process, and this is the inferior articular process, connected to each other by bars interarticularis. Bars interarticularis means that this a dense bone connecting this part and this part. This is the superior articular process, and this is the inferior articular process. Again, spinous process, and this is the lamina. Lamina extended up with the superior articular process and the inferior articular process. The most lateral part of the lamina, and the part which connects the superior and the inferior articular process, is called the bars interarticularis. This is the transverse process. The superior articular process, we are seeing the spine from the back now. This is the coronal view, AB view. Superior articular process is like this, and the inferior articular process catching, like a hook catch mechanism, just introductory for spondylolisthesis. So again, superior articular process and the inferior articular process hooked with the superior articular process of the superior articular process is articulating, this part is articulating with the inferior articular process of the cephalic vertebrae, and the inferior articular process, which is located medially, posteromedially. articulating with the superior articular process of the caudal vertebrae. Okay. They are classifying the disc according to its location to central part in the central canal. Subarticular part, this facet is a joint, is a synovial joint. And the part of the disc in that region is called the subarticular region. Just lateral to this articular region is the foraminal region. The foramen. This is the foraminal region. Just lateral to the subarticular region. Then, after the foramen, to the transverse process is extraforaminal or far lateral. Pathogenesis. I inform you that the disc is composed of annulus fibrosus and nucleus pulposus. Annulus fibrosus and nucleus pulposus is avascular, and they take their vascularity from the diffusion from the end blade. So, if the diffusion or the end blade is cracked, whatever the cause, they lose their vascularity or nutrient. Also, disc acting as menisci. They are composed of annulus fibrosus and the nucleus pulposus. The annulus fibrosus make this compression forces from the above the vertebra and the below vertebra doing a compression in the nucleus pulposus. And this compression making an axial force. But the nucleus pulposus do like a hysteresis. Condensate the force and distribute it on the end blade. Pathogenesis in normal disc nucleus pulposus imbibes and release water, as I inform you, and hoop stresses. Okay. Disc herniation by itself isn't painful, maybe not painful. You need disc herniation and you need some inflammatory markers and you need compression on the nerve to make the things painful. So you need a combination of these three elements. Natural history, you have to inform your patient that this disease, orthopedic disease, is curative and naturally subside with spontaneous resolution on more than 90% of cases. If you leave this patient without helping him, without medication, he will get relieved, inshallah. And also, they found that surgical candidate and non-surgical patient, they have the same and equivalent results after 5 years. So you have a strict indication to do a surgery for this patient. You need a very specific indication to do a surgery for this patient. Another classification we inform you about anatomical classification before. Another axial classification. This is the nucleus pulposus and this is annulus fibrosus. If it is protruded but still surrounding by intact nucleus pulposus, confined to it, it is called a protruded type. If it is pierce the annulus fibrosus just with the border of the annulus fibrosus or extended beyond the border but still connecting to nucleus pulposus material, they are called extrusion. These two parts are extrusion, and this is sequestration. Sequestration separated part from the nucleus bulbosus. For you, protruded part usually willing to heal, willing to subside, because it is not subjected to our body reaction. Still has a water, its size doesn't decrease because the annulus is connected. And the sequestrated part is the most dangerous. This is a floating material, could compress the cord itself or the root. History and physical examination, I don't think that we need to regain and review the examination before we did. We do an excellent history before. Main complaint and its associated complaint, sensory and motor and reflexes, and detect from the history of the dermatome, asking about the sphincteric disturbance and constitutional manifestation and the other joint affection. Then we start with examination by looking about splints, foot drop splints or crutches, and then analyze the gait and inform our Stampa symmetrical smooth transition between swing and stance phase. Then going to inspection from the front side back, palpation, spinous process and the paramedian sacroiliac joint, movement, range of motion, and examination neurological وفبر. This is a system. Even if my system doesn't make you happy or doesn't make a sense for you, do your own examination and train yourself on it. And please don't forget any points. We are focused about points which is important in real life and in examination. Imaging. Plain X-ray is mandatory, and we ask it in two situations, either after 1 month of persistent treatment or if there is a red flags, as we informed you before, constitutional symptoms in the history like fever or weight loss, you have to do X-ray to exclude tumor and the infection. Also, persistence of symptoms and red flags like trauma. Red flags like trauma. If you have a trauma, you have to do X-ray to ensure that everything is okay. So it is for exclude other causes of pain, not for the disc itself. Otherwise, uniform finding narrowing of disc space, which you didn't know if this narrowing is normal for him or osteophyte formation. Anyway, so you do X-ray when? After 1 month, and when you find red flags like constitutional symptoms, fever and weight loss, and also trauma. Also, the importance of X-ray, one of the most important cause for failure of discectomy is the wrong level. You come to a wrong level, and one of the most important cause to coming for a wrong level, that you couldn't, for some reason, you couldn't number your vertebrae good. For example, there is some sacralization or lumbaralization deformity, which makes sacralization means that one of the lumbar vertebrae become a sacrum, part of the sacrum. And the lumbaralization, some, some part of the sacrum become lumbaralized. So you get misleaded by this. And also spina bifida. Spina bifida, you have to see, because when you coming inside and make your dissection, you don't want your instruments to sink down in the to the dura. Sure, MRI is a study of a choice to know which part is. This disc can be hidden in some parts, like in the subarticular part, in the lateral recess, or even in the central part. It could be in the axilla of the root or the shoulder of the root. So through the MRI you can detect its location. I will inform you some simple basic knowledge regarding MRI in the last of the lecture. Differential diagnosis. Differential diagnosis, I mean by this slide, differential diagnosis of low back pain. Low back pain could be a cause in the back or outside the back. And this is the most important. Outside the back, we did Faber test for the sacroiliac joint. And you have to do piriformis test for piriformis syndrome. This is, although it is rare, but it is one of the causes. Also, if your patient has a colon intestinal problem, irritable colon, it could be a cause. So extraspinal causes you have to exclude before intraspinal. Intraspinal lesion, intraspinal at the level of the nerve root is your curriculum, and proximal to the nerve root is the cord. For us is conus and coda. Or intrinsic in the material of the nerve fascicle, like diabetes, alcohol, or chemotherapy. Chemotherapy, radiotherapy is a common causes, and they willing to improve after surgery. So you exhaust yourself with conservative management. Okay, non-operative management. Non-operative management, I inform you, natural history, 90% of cases will be okay without your hand. But you can accelerate this improvement. Non-steroidal, bed rest, avoid bed rest more than 3 days, can make a lot of muscle wasting. Enhance with physiotherapy. Injection is a good idea in resistant and prolonged period. And this conservative management, you can wait. If there is no progressive strict indication for surgery, I'm waiting actually more than 3 months. I can wait for 6 months. Except if I have a strict indication for surgery. Okay, so strict indication for surgery. You have an emergency part, which is coda or conus. Separate lecture for conus and coda to detect its importance. Coda and conus, there is a huge disc at the level of the conus or the coda, which compress the nerve root and affecting its function. Has a sphincteric and the motor and sensory. So you willing to wait till the morning, not 3 months, till the morning? No. You will do an urgent decompression. The neurology which you find, like weakness in L4 or L5, for example, by itself isn't a pure indication for surgery. Progressive deterioration for the function. I forget to add a grading system for motor system for motor evaluation I will add. Anyway, if there is a progressive deterioration in the motor sheet, in the ASIA sheet previously described, you can do a decompressive surgery, discectomy, or persistent of manifestation for more than 3 to 6 months. Persistence of symptoms despite medical treatment, he won't return to his job. Even if he know that the results now is the same as after 5 years between surgical and non-surgical, but he needs his job, he needs to return, he needs to earn his money to do his life. He can't do anything, so it is a good indication for surgery. So 3 indications. Emergency part is coda and conus. This is an emergency part, and progressive neurological deterioration, and the last one, failed conservative management. Techniques either open or micro discectomy. Actually, micro discectomy the same as open discectomy, except that we use microscope. Sure, it is better because has its light source, so you see good, and its magnification power can be used in the open with loop with trans illumination could do the job. Just a simple hint about microdiscectomy or discectomy. The patient is prone in his position like this. His abdomen should be free and all bony elements should be padded. Be careful about the head. Eye, don't increase position your head in a position to be relieved for the cervical and his eye. This sponge is very good. The C-arm should be free to see everything, and posterior by posterior midline incision, posterior. The disc is protruding mostly through the posterolateral part of the annulus fibrosus, and this area is a weak area. Weak area, I mean by weak area, a stress riser area, different direction of fiber, which makes the posterolateral part most common site for herniation, disc herniation. And this posterolateral part of this is much more central. This is, if here it is posterolateral, central and posterolateral could be approached by direct posterior, but far lateral in this area is approached by paramedian incision, which is called Wilts approach, paramedian incision, going to the transverse process and trying to catch the fragment which is far lateral, extra foraminal or foraminal. Usually it is approaches with paramedian incision. So posterior midline incision for the most common posterolateral or central part, and far lateral for done with Weltis approach or paramedian approach through the muscle. This is very rare. Posterior midline incision is the most common. You do a subperiosteal dissection of multifidus muscle and retract them till the facet. This is the facet. This is the superior articular process of the caudal vertebrae. And coming from inside is the inferior articular process of the caudal side. Anyway, you try not to affect the facet joint, its capsule. Don't injure the facet capsule, and don't do a lot of decompression in the facet. Don't take a lot of bone from the facet. Please don't destabilize the facet. You do a partial laminectomy or laminotomy, just partial, till reaching the disc and catching the material. This is not a detailed, just a simple knowledge, and we will, if needed, I will do a separate lessons for all surgical procedures, inshallah, after finishing our curriculum. Complication, wrong level is one of the most important complication. So please review preoperative image and confirm intraoperatively. Iatrogenic instability, which I inform you, you take a lot of facet. Don't take a lot of facet. Dural tear. Dural tear could be done. If it is done, you have to make exposure good, and we use a suture if it is repairable, non-absorbable suture as Prolene 60. You take it, better with microscope. You put a cottonoid to do a suction. This is cottonoid. This is like a sponge, and connected to something like string to catch it, and you put your suction on it over the dura, not to avoid injury to the dura by the suction. And already the suction has a hole near your hand. Don't put your thumb or your index on the hole to decrease the pressure of the suction. Try not to trap the fascicles of the nerve in the root. So by Penfield, you push the fascicles inside the dura and take either interrupted or running stitches as you can with 60 non-absorbable suture. If non-repairable, usually I take a part of the thoracolumbar fascia, which is the subcutaneous fascia. Once you open midline, posterior midline incision, there is a thoracolumbar fascia. I take a part of it and put it and close in maybe up to 5 layers. Try to take a lot of layers if you have a dural tear to avoid coming of the CSF to your wound and will be closed. So try to bury your mistake or incidental durotomy during tight decompression or revision surgery. This is some sort of hemostasis, parts of hemostasis, gel foam, outcome, excellent result with surgery and without surgery. So you have a strict indication to do a surgery. Some simple exam question. Please inform me what you see. Usually he tell you what you will do for this patient. Don't hurry for surgery or non-operative management, whatever. Please tell him that I want to take a proper history from the patient, including main complaint, associated symptoms. I want to do a proper examination starting from gait and neurological examination. So please inform me what he complained of. And sure, either the patient in your clinic or in the exam, he will tell you what his complaint. Then you describe the MRI. Before MRI, you have to inform where is the X-ray. Please be systemic, boring surgeon. To be a safe surgeon, you have to be a systemic man. He give you an X-ray, either the patient in the clinic or the starting again by history and what is done. Be a systemic is a safe surgeon and good, very good quality surgeon. Okay, this is X-ray. If you see, as this is MRI, if you see the CSF here white in relation to the cord, it is T2. T2, H2O, white. So T2. And usually this is the nucleus pulposus, which is hydrated, so it is white. And the annulus fibrosus, which is attached to the bone and type 1 collagen, is black. This is a black disc. For 5, mostly for 5, if there is no sacralization and rubberization, separate topic. 5 and the S1, there is a disc protrusion, extrusion, but not sequestration. L5S1. And it is compressing to the traversing nerve root on the left side. Usually MRI has a defect here. Put it on the left side. So adjust according to the marker here. Here, standardized, I think, over all the world. If not computerized, if in the films, he has to put something here which is left side. So this patient should complain of left side leg pain. If he has no, and should be S1. S1 is compressed here between L5 and S1. S1 is compressed. So if I find L3 distribution, he tells you that his thigh is aching him. So what is the relevance between neurological examination and MRI? Sure, this patient isn't an ideal or there's something wrong in your diagnosis. When you want to touch your patient, everything should be okay. So what is the features, history and the examination you are looking for? You inform, you do your systemic examination, how you would treat the patient, non-operative usually. If there is no strict indication for surgery, I will conserve him with non-steroidal bed rest no more than 3 days, physiotherapy and so on. What would you expect to find in this patient? Again, history and the examination. Please, when you see an X-ray like this, don't tell that it is scoliosis. Scoliosis means that there is a rotation. 3 plane deformity. 3 plane deformity, one of the most important plane of deformity is rotation. Rotation. There is no rotation. I'm sorry for bad quality, just I want to inform you about the idea. This just a tilt. Could be scoliotic tilt. Scoliotic tilt means that the patient with lumbar disc disease, and you see it already in your clinic, coming like this. He wants to open the space. To make his nerve root free. Okay, steroid, what is the complication of injection? Simply no improvement. It could do infection, discitis. And due to the injection material, could increase the pressure inside and causing more damage. If you injury the nerve itself, which is very rare, it could cause neurological injury. Thank you so much, and we will continue inshallah. Good luck.